Imagine for a moment that the simple things you do every day, chewing your food, talking, even just a big yawn, suddenly became really painful or maybe impossible.
It's a difficult thought.
Yeah, it's jarring. But for some people, that's exactly what happens after a very specific kind of injury. So today, we're doing a deep dive into exactly that. Mandibular condyle fractures. These aren't your typical broken bones. They're unique injuries right in the jaw joint.
That's right. They're distinct from other facial injuries, and they cause some really significant functional problems.
Our sources for this deep dive include comprehensive medical chapters, some key research excerpts. Basically, we're aiming for a detailed but understandable look.
We'll get into the functional anatomy, how the jaw actually works, what happens when it breaks, and the different ways doctors approach treatment. It's quite fascinating.
Right. So our mission is to unpack why these fractures mess things up so much functionally. We'll look at the treatments, conservative versus surgery.
And the surprising things that affect how well someone recovers.
You might even have a few aha moments about your own jaw. So let's start with the basics. The star here is the mandibular condyle.
Tiny bone, huge job.
Exactly. It's part of the temporomandibular joint, the TMJ. And the TMJ isn't just the condyle, it's the condylar heads, these little discs in between, the sockets in the skull. It's a whole system.
And the mechanics are really unique. It's not just a hinge. You've got two joints, one on each side, working together. They're called diarthroidal, freely movable.
Encased in a capsule.
Right. And ginglymoidal. Fancy word.
This just means it acts like both a hinge and it glides, right?
Precisely. It allows for a really wide range of movement.
And that movement, the dance of the jaw, happens in two stages.
First, when you just start to open, maybe the first 15, 20 millimeters, it's mostly rotation, like a hinge.
Okay.
But to open wide, say 40 or 50 millimeters, the condyles have to translate. They actually slide forward and down along a slope in the skull base.
And that smooth slide depends on those little articular discs having some elasticity.
Exactly. The discs, especially the tissue behind them, and the joint capsule with its ligaments, they're crucial. They let it glide forward but stop it from going backward.
And here's something really interesting from evolution. The condylar necks, that narrow bit,
Yeah.
they're kind of designed to be a break point, like a fuse.
To protect the brain.
Exactly. They break to absorb impact, protecting the skull and the brain case. That's why it's actually pretty rare for the condyle to get pushed backward into the skull. Amazing built-in protection.
That is amazing. And this whole complex setup lets us chew and bite effectively. Intricate movements, how the teeth separate just right, specific tooth contacts.
All guided by the condyles and nerve signals. It's a really harmonious system.
It is.
So you can see why a fracture there causes such big problems. It's not just a crack in a bone. It disrupts this whole finely tuned machine.
Absolutely. The immediate fallout impacts your bite, how your teeth meet your chewing, maybe even your airway and speech. These aren't subtle issues usually.
Let's talk specifics. What does someone actually notice?
Okay, well, one common thing is the bite feeling off on the injured side, like the teeth hit too soon there.
Prematurity, they call it?
Ipsilateral occlusal prematurity, yes. It's because the joints lost some vertical height, so the jaw might kind of rock into a final bite that looks okay, but it isn't right functionally.
So you might not be able to bite down fully, get all your teeth together properly.
Right. You might only hit on one back tooth on that side. That creates what looks like a wedge-shaped gap at the front, an open bite.
And if both sides are broken,
then you can get a really large open bite at the front, sometimes called a gag bite. And if there's another fracture, say down at the chin, the face can actually widen, and the back teeth can end up in a crossbite.
Wow. What else? Does the jaw shift?
Yes, it often shifts towards the side of the injury. That's called laterognathia.
Yeah.
And when you try to open...
It curves towards the bad side.
Exactly. An arc-shaped deviation. You can see it clearly.
Okay. Any other bite issues?
Yeah, sometimes when you try to move your jaw sideways, the teeth on the opposite side might bump incorrectly. We call those balancing side interferences. It happens because the injured side's ramus is functionally shorter.
And just opening your mouth can be difficult, right? Trismus.
Very common. It could be the bone fragments physically blocking movement, or maybe muscles getting impinged, or just swelling and pain in the joint itself.
It's clear these have major functional impacts. Now, you mentioned fracture types.
Right. Generally simplified into 3 based on location. Subcondylar is below the neck.
Okay.
Condylar neck fracture is in that narrow part, but outside the joint capsule.
Got it.
And then condylar head fracture that's inside the capsule involves the actual joint surface.
Yeah.
More serious.
But these aren't just medical terms. They're real changes affecting eating, talking, even appearance. It hits daily life hard.
Absolutely. Which brings us to treatment. The goals are always the same. Get back pre-injury function and let it heal properly.
But how to do that? That's where things differ. Let's start with closed treatment.
Okay. And it's important to understand closed treatment often isn't about reducing the fracture in the traditional sense, like setting a broken arm perfectly. It's more about rehabilitation.
Guiding the healing.
Exactly. You use arch bars or other appliances to get the bite back to where it should be. Historically, maybe they'd wire the jaw shut for a week or two.
Not fun.
No. But now, it's more common to use guiding elastics right away, specific rubber bands pulling the jaw gently towards a good functional position.
And rehab is key here.
Absolutely critical. Early range of motion exercises, physiotherapy, encouraging the jaw to move, and the body's ability to adapt is, frankly, amazing.
How so?
Through something called functional neuromuscular adaptation. Even if the bone isn't perfectly aligned, the nerves and muscles can often figure out how to make it work surprisingly well. The condyle might even form a neoarthrosis.
A new joint surface.
Sort of, yeah. It starts functioning a bit further down the slope on the skull, accommodating small changes in bone position or bite.
That's incredible.
Mm-hmm.
What do studies show about closed treatment outcomes?
It's a bit mixed, honestly. Some early studies found few obvious problems, and patients were generally happy.
But more recently?
More recent work shows some patients might still have pain or feel their bite isn't quite right, even if they can open wide. Interestingly, patients often think their opening is normal, even if it measures a bit less than before.
So perception versus measurement.
Right. And while closed treatment often results in a slightly shorter ramus height on that side, maybe 5 millimeter.
The body often compensates with that neoarthrosis thing.
Often, yes. It adapts.
Okay, let's switch gears. Open reduction and internal fixation, ORIF, surgery.
The big advantage here is getting the anatomy perfect or as close as possible right away, putting the pieces back exactly.
And fixing them rigidly.
Yes, with plates and screws. This allows for immediate function. Patients can start using their jaw fully much sooner.
But it sounds technically difficult.
It is. It requires specialized training, special equipment.
Yeah.
Getting access to that joint surgically isn't easy. Visibility can be poor. You've got the facial nerve right there, the parotid gland.
And scars.
Aesthetic concerns, definitely. But endoscopy has been a huge advance, using tiny cameras.
Better view, smaller incisions.
Much better view helps confirm the reduction is accurate. It's made a big difference. Common approaches are behind the jaw, the retromandibular approach, which works well for endoscopy, or near the ear, the preauricular approach, for fractures inside the capsule.
Still balancing access versus risks.
Always. And even with good surgeons, getting the alignment just right can be tricky. That's why intraoperative CT scans or navigation systems are sometimes used to double-check the position during the surgery itself.
So when is surgery the definite choice?
There are absolute indications, like if the fracture goes up into the skull base, or if something's physically blocking the jaw from opening, or if you simply cannot get the bite right with closed methods.
Okay. And relative indications, when it's probably better.
Things like bilateral, both sides broken, especially with other bad facial injuries where wiring isn't practical, or if the patient has medical issues like a severe seizure disorder where wiring is risky, or sometimes if their original bite is unknown because of missing teeth.
What are the outcomes like for ORIF?
Generally good, especially with endoscopy. Studies show high rates of good anatomical reduction and normal bite afterwards. And importantly, the risk of permanent facial nerve damage seems pretty low with modern techniques, which is reassuring.
Okay, so we have these two main paths, closed and open.
Yeah.
But recovery isn't just about which path you take, is it? There are risks with both.
Definitely. Both have their own set of potential complications.
For open surgery, we mentioned nerve injury. That's a big one, right? The facial nerve.
Yes, cranial nerve 7. Different branches are at risk depending on the surgical approach. Temporary weakness is a known risk, maybe around 17% with the retromandibular approach according to one study, but it usually resolves.
What about infection?
Also a risk with ORIF, sometimes linked to blood supply issues to the condylar head, or if the fracture went into the ear canal, or if treatment was delayed.
And scarring, you mentioned that.
Yes, patients do complain about the perception of scars. Endoscopic techniques done through the mouth can help avoid visible facial scars, which is a plus.
Interestingly, what about chronic pain?
Yeah, this is surprising. Some studies suggest open reduction might actually lead to less chronic pain long-term compared to closed treatment. But overall, chronic pain seems relatively low with either approach once things heal.
Now, things get really complex when you factor in the patient themselves. age makes a big difference.
A huge difference. Younger kids, say up to age 11, generally do better. Their bones remodel and adapt incredibly well.
But there's a downside for kids.
Yes, a condyle fracture in a growing child can sometimes affect facial growth, leading to asymmetry or bite problems down the line. It needs careful monitoring.
And older patients.
Elderly patients or those without teeth tend to adapt less well. Less compensation happens naturally.
What about gender?
There are some observations, particularly in adolescence, that females might have more functional issues, maybe linked to higher rates of general TMJ disorders in females. It's not fully understood.
And general health. Things like diabetes, smoking.
Anecdotally, yes. Systemic diseases, smoking, heavy alcohol use, maybe certain medications like bisphosphonates or steroids. These are all thought to potentially hinder healing, although direct evidence specific to condyle fractures is sometimes limited.
And then there's patient compliance.
Yeah,
How much the patient sticks to the plan.
absolutely critical, especially for the rehab phase. And studies show compliance can be a real problem. Patients don't always come back for follow-ups or do their exercises religiously.
Which undermines the treatment.
It really can. Even a perfectly treated fracture won't have a great outcome if the rehab isn't done properly.
Might characteristics matter too, like someone's natural bite.
Yes, someone with a naturally steep jaw angle or a shallow bite might be more likely to end up with an open bite after closed treatment. A deep bite might be more forgiving of slight shortening.
And habits like grinding, bruxism.
That can be a problem after ORAF. The strong forces can actually break the fixation plates. Sometimes Botox is used to temporarily weaken those strong jaw muscles during healing.
Okay, you mentioned the functionally shortened ramus earlier. Let's unpack that. It's not just about measured length.
Exactly. You can measure the bone, that's anatomical shortening. But functional shortening means the condyle ramus unit just isn't supporting the bite properly, even if the measurement isn't drastically off.
How did that show up?
Persistent feeling that the bite is high on one side, can't get the teeth to meet fully, or can't move the jaw sideways properly to chew on the opposite side. It's a key sign that maybe open reduction is needed.
Is there a test for that?
There's an intraoperative testness. Surgeons use the drop back test. If they gently push the lower jaw back and it sort of collapses posteriorly, it means the joint isn't stable vertically. That points towards needing ORF.
And the angle of the fracture.
Significant angulation, say more than 30-35 degrees, is generally considered a strong indication for surgery too.
And we can't ignore practical things, like surgeon experience or even economics.
Right. An experienced surgeon comfortable with these techniques likely gets better results with ORAF. And unfortunately, access to specialized care or certain technologies might be limited by cost or location. These are real-world factors.
All this complexity, it leads to a bit of an evidence problem, doesn't it?
And it really does. It's quite surprising, actually. Despite decades of research, major reviews conclude the overall level of evidence to strongly recommend one treatment over the other is still, well, inadequate.
Why is that?
A lot of studies historically haven't met the really high standards needed for clear, unbiased reporting. Cochrane reviews, which are very rigorous, found a real lack of top-quality randomized controlled trials.
And the trials that do exist?
They've shown conflicting results. One trial might find ORAF gives better opening and less pain. Another, comparing similar groups, finds no significant difference in function or bite. It just highlights how complex these injuries are and how many variables are involved.
And we still don't know everything about long-term effects.
Correct. Things like what happens to the joint disc years after surgery, or how the condyle bone continues to remodel over time. These are still areas of active research we're still learning.
So what's the bottom line here?
The bottom line is that both closed and open treatment methods definitely have a place. Both have been shown time and again to lead to acceptable outcomes for many patients, meaning pain-free function, good aesthetics.
The key difference being?
Open treatment's main advantages are getting that precise anatomical reduction and allowing immediate full function. Closed treatment's advantage is avoiding the risks of surgery, anesthesia, bleeding, infection, nerve injury.
So it really has to be personalized.
Absolutely. You have to tailor the plan to the individual patient, their specific injury pattern, their health, their lifestyle, and even the resources available for their care. There's no one-size-fits-all answer.
Okay, so we've really dug into mandibular condyle fractures. We've seen the intricate anatomy, the serious functional consequences of a break, that cool evolutionary breakpoint idea. We've looked at closed treatment, focusing on rehab, and the body's amazing adaptation, and open treatment, aiming for anatomical perfection, but with surgical risks.
And all those patient factors, age, health, compliance, that muddy the waters.
Right. It all comes down to an individualized approach, balancing the goals with the risks for that specific person.
Which leads us to a final thought for you to consider. Given the body's incredible ability to adapt that whole neuroarthrosis concept where it can almost build a new joint surface,
Yeah.
and given the ongoing difficulty in proving definitively that one treatment is absolutely superior across the board, what does this deep dive really tell us about the limits of our medical interventions, and maybe about the sheer resilience of the human body itself?
That is something to chew on. Definitely
Yeah.
makes you appreciate how much that little jaw joint does without us even thinking about it.